So without further ado, I'll get started. So I have the pleasure of giving you the clinical talk. I have tailored this, so I hope it won't overlap too much with what follows. This is the infectious diseases section. So the types of encephalitis I'll be speaking about will predominantly relate to infectious etiologies. I will mention very little about, I won't mention anything actually about COVID-19 because there's a whole session on that later on. So, and I aim to speak for 20 minutes and to allow about 5 minutes for questions thereafter. So, when we think about infectious causes of encephalitis, certainly in the resource-rich world, we primarily think about herpes simplex encephalitis. And here is perhaps where things have gone wrong, post-mortem tissue. On the left, macroscopically, showing a coronal section through the brain and the temporal lobe. And here you can see a necrotic hemorrhagic process macroscopically and potentially some mass effect. On the right, you can see under immunohistochemical staining in brown for herpes simplex antigen within the substance of the brain tissue, thereby demonstrating that not only is there inflammation there, the hallmark of encephalitis, but also the presence of an organism, and we can see the antigen there. So this is very definitely a infectious process. But microbes can affect CNS function in many different ways. It can do so like this through invasion of the parenchyma of the brain, such as happens in viral encephalitis, but also in pyogenic abscesses with cerebral abscesses. Bugs can also infect the supporting structures of the brain, such as where the chickenpox virus VZV causes a large vessel vasculopathy. But in these cases, the damage to the brain is predominantly through ischemic stroke. But there are other mechanisms through which microbes can affect CNS function indirectly. It can trigger, infections can trigger immune-mediated central nervous system damage, such as post-infectious or para-infectious acute disseminated encephalomyelitis. Infections are now recognized to trigger autoantibody-associated forms of encephalitis. And in immunosuppressed patients who are taken off immunosuppression or HIV patients who are immune reconstituted, that too can in some cases result in brain inflammation called ARIS. Infection rarely can trigger metabolic catastrophes. In adults, first described by Capilla in the context of influenza infection, but perhaps better known in children as Reye's syndrome. We know that influenza can also trigger acute necrotizing encephalopathies. Peripheral bacterial infections such as tetanus can release a toxin that has a direct effect on the central nervous system. And more systemically, systemic sepsis can cause encephalopathy in its own right. And this perhaps is the major clinical differential diagnosis when one sees a patient with fever and encephalopathy and are considering the possibility that the patient might have an encephalitis. So what's the incidence worldwide of acute infectious encephalitis? Well, it varies geographically around the world, but within the UK, it's approximately 5 or so per 100,000 per year, which is similar to the incidence of bacterial meningitis. In other parts of the world, higher incidences are described. Now, for acute infectious encephalitis, we often think of viral causes, and if you open the standard textbooks, you'll see long lists of potential etiological agents. There are other infectious causes of encephalitis, particularly intracellular bacteria, such as Listeria or Coxiella burnetii, rickettsial type organisms. But rarely other bugs can cause an acute encephalitis as well, including parasitic organisms. But faced with a long list like this, one needs to organize thoughts and be a little bit more targeted. And I'm going to take you through some data to try and help with that process. This is a paper referring to a study performed about 15 years ago in the UK. There have been similar studies subsequently, and hopefully we'll have some more data with UK information published perhaps this year. But this study looked prospectively in England at 3 sites, 3 areas of England rather, looking for patients presenting with an acute encephalitic illness. They had to be HIV negative in this study, and it involved adults and children. So what did they find? Well, first of all, with the broad case definition, effectively, of encephalopathy, fever, active CSF, what processes were found to mimic acute infectious encephalitis? Well, I'm showing you this slide just to show you this excluded box here. So what things present acutely that can be mistaken for acute infectious encephalitis? Well, things such as venous sinus thrombosis, the posterior reversible leukoencephalopathy syndrome, brain tumors such as primary CNS lymphoma or glioma, epilepsy, septic encephalopathy, etc. But what are the patients who were found to have an acute encephalitic process in this study? What were the etiologies? Well, far and away, the commonest was herpes simplex virus. The majority were HSV type 1. What after that? Well, virus-wise, varicella zoster, a few enteroviruses, and some bacterial causes, including TB. Perhaps an underestimate in this study, or failure to recruit, perhaps too few enterovirus infections were found. What else was found in low numbers? Listeria, much more common in other parts of the world, particularly in France, where a contemporaneous study showed about 10% of acute encephalitides related to this organism. So in this study, about 2/3 of patients were found to have a definite etiology. The majority of these were infectious, 86, you can see up there, but about 1/3 of those in whom a definite etiology was found had an immune-mediated cause for their encephalitis. The commonest etiology being acute disseminated encephalomyelitis, ADEM, and in fact, in a few cases, the triggering etiology was also found. Because this study recruited patients about 15 years ago, the autoantibody forms of encephalitis were not routinely sought. And actually, in this study, the autoimmune antibody-associated forms of encephalitis were all diagnosed retrospectively. And that's important as we move on, as I will show you. So in this slide, I briefly show you outcome from this cohort. So the overall case fatality was about 12%. It was worst in those patients who had TB associated with their acute encephalitic presentation. And second to that, with the antibody-associated forms of encephalitis, where it was 19%. This is far higher than you would find in contemporaneous studies of autoantibody-associated encephalitis. And the reason being, these cases were only identified in retrospect. The best outcome was in persons suffering from ADEM, in patients with HSV encephalitis, so the commonest cause of acute infectious encephalitis in this cohort. 10% of patients died. 61% had a poor outcome, meaning a Glasgow outcome score of less than 5, so moderate disability or worse. But many of these patients with herpes, who survive herpes simplex encephalitis, have significant acquired brain injuries, for which, from this data, you really don't get an appreciation. What about those patients in whom an etiology wasn't discovered? Well, still in 10% of those, there was a poor outcome. Half, 47% a poor outcome, 10% died. So going back to that original study, that original slide rather, What things should we look at for virus-wise in patients presenting with acute infectious encephalitis? Well, we should look for herpes simplex types 1 and 2, varicella zoster virus, and enteroviruses. So, at the bedside, how do we go about making a diagnosis of acute infectious encephalitis? Well, we need to fuse the neurological formulation with the work of an infectious diseases physician, thinking not only about the host, but also about potential organisms. And of course, on the neurological side, trying to define the anatomy and the pathogenetic mechanism causing the syndrome in front of us. So the cardinal symptoms and signs of acute encephalitis are fever, alteration in level of consciousness, and seizures. The highest incidence is usually in the extremes of age. What we see at the bedside, such as focal or lateralizing neurology, can often tell us about the disease process, meaning in an infectious cause, it can tell us about the neurotropism or the neuronotropism of potential organisms. But even in autoimmune causes, the pattern can give us a good clue as to etiology. And patterns to be aware of are the limbic pattern, such as associated with herpes simplex encephalitis, or the autoimmune encephalitis associated with NMDA antibodies, brainstem encephalitis, such as the rhombencephalitis associated with listeria. Involvement of the spinal cord with encephalitis is a clue that ADEM might be etiological. Involvement of anterior horn cells gives a clue that on the infectious side, enteroviruses or flaviviruses may be at play. There are sporadic and epidemic causes. Herpes simplex is sporadic. Enteroviruses more common in the summer and autumn. History taking is key. We need to know what exposures the host has had. Have they had contact with animals, vectors such as viruses and ticks? And it's critically important to think about the immunocompetence of the person in front of you. Every patient presenting with suspected encephalitis warrants an HIV test. So worldwide, different etiologies to here in the UK. Mosquito-borne infections, very important. They can carry flaviviruses. Perhaps the best studied of these is Japanese encephalitis in the Far East. But elsewhere in the world, there are other flaviviruses such as West Nile virus in the Mediterranean basin and North America, and St. Louis in North and South America. Of course, when you see somebody returning from a tropical place with fever and encephalopathy, always think of malaria. In Europe and now within the UK, also think about tick-borne conditions, including tick-borne encephalitis. If you're faced with somebody who's immunosuppressed, and particularly somebody who's had an organ transplant, remember to think about where the organ has come from, the donor, and from what they have died from, and what may be transmitted with the donor organ. So, in the last 5 minutes or so of this talk, what can we gain from investigations? Well, imaging helps us define the anatomy of the problem. It can identify whether there's raised intracranial pressure and issues relating to intracranial pressure management. Here you can see 3 CT scans over a period of approximately 72 hours or so of a patient who initially presented with new onset seizures and fever. The CT scan on the far left was reported as normal. 36 hours later, the patient returned with further seizures and a fall in level of consciousness. And now you can clearly see a swollen brain. This is an unenhanced scan. There's an area of hemorrhage, and there is midline shift. The patient had herpes simplex encephalitis, but their life was saved acutely by the decompressive hemicraniectomy that you can see on the right. MRI is more sensitive. This is an MRI from scan hyperacutely in a patient who was shown subsequently to have herpes simplex encephalitis. Her symptoms had come on only hours beforehand, and you can see early changes in her non-dominant right temporal lobe here on the FLAIR imaging, with subtle DWI and contrast enhancement. It's really unusual for a patient with herpes simplex encephalitis to have a normal MRI brain scan by 72 hours into the disease process. Other things, other conditions, as we talked earlier, can cause temporal lobe changes. This is a nice paper from the California encephalitis study some years ago. And on the left here, you can see other organisms at the top here causing temporal lobe changes, imitating herpes simplex encephalitis, including enteroviruses, varicella zoster virus, West Nile, but also rarer causes such as Balmuthia. But of course, there are non-infectious causes that can affect temporal lobes, such as gliomas, as well as down here, autoimmune causes. Is there anything in particular that points towards herpes simplex encephalitis more likely being the cause? Well, lesions outside the temporal lobe cingulate or insula are the only things that statistically hold true. Herpes simplex virus may affect other parts of the central nervous system, here causing a brainstem encephalitis, where at presentation the patient was not encephalopathic. Other viruses target different parts of the brain. This is a case of St. Louis virus encephalitis, and here you can see characteristic changes in the thalamus and within the corticospinal tracts. CSF is integral for demonstrating evidence of inflammation and also for detection of organisms, particularly viruses, using PCR tests. CSF can have normal white cell counts even in herpes simplex encephalitis when the CSF is sampled very early in the disease process. With all virulent CNS infections, the chance of picking up a virus by PCR is highest when the CSF is sampled a day or so after symptom onset. Hyperacutely and remotely after onset of symptoms, less likely to pick up a virus by PCR. For the flaviviruses, PCRs are not the best test, and CSF antibody tests are more helpful. For West Nile and for Japanese encephalitis, CSF IgM tests. And antibody tests can be helpful for proving herpes simplex or varicella zoster virus etiologies down the line. Usually by day 10 to 14 after symptom onset, intrathecal antibodies are present. So, coming to the end of the talk, how do you manage encephalitis? Well, resuscitate the patient, sort out the investigations. If there are no contraindications, get on and get a lumbar puncture quickly. Treat with intravenous acyclovir. If you prove it to be herpes simplex or varicella zoster virus, then treat for 14 days. I recommend, and some other authorities recommend, repeating a lumbar puncture to ensure the CSF is negative by PCR before stopping acyclovir. What can catch you out? Antibody-associated encephalitides. Here are some red flags. Subacute onset, prominent initial psychiatric symptoms, bizarre movement disorders, seizures resistant to multiple anti-epileptic drugs, lack of MRI changes or disproportionately little for the clinical state, modest CSF, lack of fever at presentation. These are all flags for thinking about antibody-associated forms of encephalitis. And I think it's 20 past, so I shall leave it there with this slide that gives you some resources to the UK adult and pediatric guidelines for encephalitis. I wholeheartedly commend the Encephalitis Society to you as a source of information, particularly for patients and relatives. And if there's one recent review article to look at, the Lancet article by Venkatasan and colleagues is a very nice overview. Thank you.
Brilliant, Nick. Thank you very much. I'm going to clap on behalf of everyone who's listening. So now is your chance, ladies and gentlemen, to post a question. and we have a couple of questions there already. And Nick, sorry I disappeared in the middle. I was still there, but I became a delegate again, so I was listening, but I couldn't. The sound went a bit strange. Anyway, here's the first question from Dr. Ava Easton. Given the high incidence of varicella zoster virus you showed in the study, should we be pushing for varicella zoster virus vaccination in the UK, as is the case in some other countries?
Tom, I'm having great difficulties hearing you. Your voice is staccato and broken up.
Okay, can you hear me now? Are you hearing me better now? If not, do you want to look at the question?
About varicella zoster virus.
So,
Yeah.
Tom, I can hear you actually. So it may just be the internet connection. I'll just post the question in the chat as well.
Yeah. So, Nick, we're going to post the question in the chat. Have a look. Have a look at the chat.
I can see the question. Should we push for varicella zoster virus vaccination in the UK? Well, yes, it's standard in many resource-rich countries. I should say, I didn't make clear, the majority of VZV-related neurological problems picked up in the encephalitis study was amongst immunosuppressed patients. So that's a very important thing to pick up. It seems a good idea to me. I don't know about the cost modeling. And I think one of the concerns about VZV vaccination had been whether there would be waning immunity later in life if there was less VZV circulating. I'm not a person to be able to express comments on the validity of those concerns.
Great, Nick. I don't know if you can hear me, but if not, just have a look at the questions yourself. Are you hearing me? Is anyone hearing me apart from the hosts? Maybe I'll minimize my video. Can somebody else talk to Nick so we know where the problem is, please?
I can hear both of you perfectly, actually. Okay, so the next question is from Dave. The question is, what is known about the reasons for neurotropism of HSV to medial temporal lobe structures?
Oh, I think that's a really good. So neurotropism means able to infect any cells of the nervous system. Neuronotropism means specifically neurons. HSV actually has widespread tropisms to nerves to cells of the central nervous system, which is why it's being used as a glioma treatment. So we don't think it's so much the virus itself, but why does it reactivate in that position? And nobody knows the answer to that, but people have speculated two mechanisms. One, whether it's through trigeminal innervation of the meninges around the temporal lobe, and secondly, whether there might be an olfactory entrance of the virus to the entorhinal cortex, because, as you know, it's a direct connection and the only sensation not to transit via the thalamus.
Okay, thanks. I don't know if Nick can hear me. I think, is it Lucia who's acting as interpreter? Nick, you can hear me, good. We're just about on time, but because we had some faff, let's just see if you can answer these two questions very quickly. The first one is about the false negative rate for HSV PCR after starting IV acyclovir. That's from Dr. Yi Xian. And then secondly, as antibodies take a while to come back and CSF can be similar, when do you give steroids in patients with HSE? That's from John Bowen. So first one about false negative PCR, second one about when to give steroids in patients who don't have HSV.
So acyclovir per se doesn't quickly drop HSV DNA levels in CSF. Yes, the CSF can be so-called falsely positive, meaning that not that it's a lab error, but we haven't picked it up. And that's usually due to timing of the CSF sampling. So if the patient looks as if they've got herpes simplex encephalitis, the CSF is negative, then go back and repeat the CSF after 24, 48 hours. The second question related to steroids, very good question. The chair of our session is a particular expert in this area and is running a very important research study to look and answer that exact question. Currently, until we've got the results of that study, I only use steroids in proven herpes encephalitis if I'm worried about mass effect. But watch this space. We may have more information there in a year or two.
Thanks, Nick. Thanks again for a great session. Sorry about the technical challenges, but I think that's just the nature